Okay, hello everyone. Dr. Shanzi here. I'm going to just take you through gestational trophoblastic disease. Yeah, can everyone hear me?
Yes, doctor.
Yeah, so gestational trophoblastic disease can be quite a technical topic, but we'll try as much as possible to simplify it so that everyone is on the same page and everyone understands it. That's the whole point. And if you don't understand it, as usual, I think we'll try and explain it properly and have a recording and post it so that you guys can go back to the audios and listen over and over again. And also the beauty of a presentation like this is that you can ask if you are not clear about something. So let's start. Yeah, so gestational trophoblastic disease spans quite a number of conditions. It's not just one condition. So it's several different kinds of diseases, so to say. So you have partial moles, you have complete moles, you have invasive moles, you have choriocarcinoma, you have what is called epithelioid trophoblastic tumor, and you have what is called placentosite trophoblastic tumor. So all these here are called gestational trophoblastic disease. So when somebody says gestational trophoblastic disease, they have all these conditions in mind. That's what you have to think about. So gestational trophoblastic disease is not just partial mole and complete mole. It's also these others. The important thing to remember is that partial mole and complete mole are what are called HYDITIFORM moles. Then the bottom four conditions there are what we call gestational trophoblastic neoplasia, generally speaking. So that is about this gestational trophoblastic disease. So we know how gestational trophoblastic arises, gestational trophoblastic disease arises. When we talk about a complete mole, we are talking about, you need to remember that we are talking about something bad, really, when you talk about complete mole. So you have a sperm that fertilizes an empty ovum, or the ovum has genetic material there, but the issue is that the genetic material is not active. So it's as good as not having genetic material there. So once this is fertilized, it makes what is called a complete mole. So you have a sperm that fertilizes an empty egg. The egg has inactive genetic material, or it has no genetic material at all, then the sperm goes into it. And the sperm kind of multiplies and makes 46 chromosomes. And if it doesn't do that, maybe two sperms go in and fertilize this empty ovum, and you still end up with 46 chromosomes. So that's what a complete mole is. So a partial mole, on the other hand, is when you have an ovum with some genetic material of this female, but this ovum allows more than one sperm to fertilize it. So it's a kind of ovum that allows more than one sperm to fertilize it. So you end up with 69 chromosomes. So because it has 23 and the two sperms that fertilize it have 23 as well. So you end up with 69 chromosomes, and these chromosomes end up making what is called a partial mole. It's partial because usually in this kind of hyaditiform mole, you have some fetal tissue there because there's been some contribution of some maternal chromosomes, some contributions of some paternal chromosomes. So there's some kind of fetus there. So the partial means that there's some, it's not completely bad tissue. There's some fetal tissue in that kind of mole, which we call a partial mole. So that's the difference. In a partial mole, you have some fetal tissue. In a complete mole, you don't have fetal tissue at all. So what is the clinical presentation of these molar pregnancies or hyaditiform moles? Usually these patients present with abnormal vaginal bleeding. So any bleeding after a woman has given birth, any bleeding after a pregnancy event should make us suspect that there's probably a molar pregnancy here. Sometimes you have a presentation where preeclampsia comes early. We remember that preeclampsia is a condition where high blood pressure is there after 20 weeks, but sometimes that happens before 20 weeks. And this is one of the situations where you can have preeclampsia happening before 20 weeks of gestation. You can have thyroid disease because the beta HCG that is produced by the molar tissue is similar in structure with thyroid hormone. It's similar in structure with luteinizing hormone, and so on. It's similar in structure to the other hormones produced in the anterior pituitary gland. So its effect is like thyroid stimulating hormone. And also the blood pressure is also due to this hormone, which is elevated. Sometimes patients with gestational trophoblastic disease can present with coughing blood when they have hair, like, you know, metastasis in the lungs, or if they have metastasis in the brain, they can present with convulsions. Sometimes they present with ovarian cysts because, like we said, the beta HCG being produced by the molar tissue has very similar structure to luteinizing hormone. So luteinizing hormone stimulates ovarian tissue and causes these cystic tissues to arise. Then this beta HCG that this molar pregnancy tissue is producing sometimes is abnormal in structure. Sometimes it's very high. The levels can be as high as 100,000, as high as 1 million. That's how high the beta HCG in this molar pregnancy can be. So sometimes you have what is called the hook effect, where when you use a normal pregnancy test in the urine, what you discover is that the pregnancy test from the urine is negative because the pregnancy test, the way it's made, the too much beta HCG gets in the way of those molecules attaching on the pregnancy test that we normally use, and it comes out negative. The other reason it can come out negative is because the beta HCG that is being produced by this molar tissue can be an abnormal kind. So your pregnancy tests fail to detect it. This is what people refer to when they talk about the hook effect, where you have a lot of beta HCG and your pregnancy test, your usual pregnancy test, fails to pick the positivity. So it's negative even when there's a lot of beta HCG in the urine. So at the moment, it's advised that if you have somebody who has had an incomplete abortion, somebody who has a termination of pregnancy, it's advisable that every one of these patients gets a pregnancy test 3 weeks after a miscarriage. after a missed abortion, after any pregnancy event, it's important that the patient gets a pregnancy test 3 weeks after that event. This is in an effort to have surveillance for molar pregnancy, because when you have gestational trophoblastic disease, this is a easily curable condition, so you don't want to miss it, because 99% of patients who have these conditions get cured. So there's surveillance that is needed so that you don't miss this patient. So you need to do a pregnancy test 3 weeks after a miscarriage, 3 weeks after any pregnancy event, so that you can we can detect this condition early and so on. In our setup, it's very difficult to take all the tissues for histopathology, but it's advised that if you have any miscarriage, any termination of pregnancy, you need to take those tissues for histopathology if you didn't see any fetal tissue there, or if you didn't have a scan that told you that there's a fetus there, then you need to do a pregnancy test, and you also need to do take that tissue for histopathology. So that is about the clinical presentation, and that's about surveillance. So what are the differences between partial molar pregnancies and complete molar pregnancies? So we've already talked about the genetic difference, which is that partial moles have maternal chromosomes there. That's a genetic difference. Complete moles have no maternal chromosomes there. That's one genetic difference. And then the other genetic difference is that complete moles are usually diploid, and the partial moles are usually triploid, as we saw in the pathophysiology and how this condition develops. Then complete mole grows fast. So you have a pregnancy that is bigger than the gestation age. So somebody's maybe 8 weeks pregnant by dates, but their superficial fundal height looks like it's for 16 weeks. That's something that you see commonly in a complete mole. Then complete moles have more medical complications, things like thyroid disease, things like preeclampsia, things like somebody having ovarian cysts, what are called thecal lutein cysts. All those conditions are much more common in complete moles. Then complete moles have a higher beta HCG if you measure, and they have a high risk of patients developing gestational trophoblastic neoplasia. So patients who have complete moles have a high risk of developing gestational trophoblastic neoplasia. So the risk of gestational trophoblastic neoplasia in complete moles is about 15 to 20%. And the risk of gestational trophoblastic neoplasia in patients with partial moles is about 1 to 5%. So we can see the difference there. Of course, we already talked about how partial moles will have fetal tissue there, they will have fetal red blood cells, they have maybe some amniotic membranes there, and so on. When you look at complete moles, there's completely no fetal tissue there. You just see all these vesicles. Vesicles which are there like villi. You know, when you look at the placenta, there's villi there. That is encroached in the maternal circulation, getting all those nutrients. But all these villi are now hydropic. They are edematous. So in a partial mole, there's some places where there's edematous villi, and there's some places where there's no edematous villi. But so you find both abnormal villi and normal villi. But when you look at a complete mole, all the villi are abnormal, all the villi are edematous. There's no other tissue there. Then if you do immunochemistry, there's a P57 protein that you can find in partial moles, because P57 protein is only found in maternal genetic material. So if you have no contribution of maternal genetic material, you will not find any P57 if you do immunohistochemistry staining. So that is about the issue of the differences between partial moles and complete moles. Then we move on to gestational trophoblastic neoplasia. So gestational trophoblastic neoplasia is those conditions which are the invasive mole, choriocarcinoma, epithelioid trophoblastic tumors, and placentocyte trophoblastic tumors. I can just quickly say that a lot of these epithelioid trophoblastic tumors, placentocyte trophoblastic tumors are not responsive to drugs. You heard in the introduction that these conditions are very easily curable, but when you talk about epithelioid trophoblastic tumors and placentocyte trophoblastic tumors, these conditions their response to chemotherapy is very poor, and usually you end up doing hysterectomy as well, apart from the chemo, and sometimes you even need radiotherapy for these conditions. So that's really the big issue there. Then invasive mole is really kind of a type of hyaditiform mole, but it has a very high propensity to like infiltrate the uterine muscles, but it doesn't go very far from the uterus. Doesn't metastasize very far from the uterus, but it has a very high propensity of going through the uterine muscles, making the uterine walls very friable. And if you are doing an MVA there, you can easily perforate. The uterus. So that is what we need to know about invasive mole. Then choriocarcinoma is the one that really spreads everywhere, spreads to the lungs, spreads to the brain, spreads to the vagina, spreads to the liver, spreads to the kidneys. So it has this high propensity to spread everywhere. But the issue again that we have to remember is that when you have these conditions called gestational trophoblastic neoplasia, clinically they're usually diagnosed through a beta HCG, because once you have a hyaditiform mole, you usually monitor beta HCG. We'll explain how that is done. But you'll see that in these particular patients, the beta HCG is not going down after the pregnancy event, whether it was a molar, whether it was a term pregnancy. After the pregnancy is gone, the beta HCG is not going down. That is usually how we diagnose these conditions, because again, in our setup, it's very hard to get histopathology. And even to get this beta HCG, it's very difficult. So anyway, the way you diagnose it is by seeing that the beta HCG levels in the blood, in the serum, are not going down. They continue to go up or they remain static, which is called plateauing of the beta HCG. So that gives you an indicator that what you have is gestational trophoblastic neoplasia and not hyaditiform mole. You remember that what we are calling hyaditiform mole is the partial mole and the complete mole. But all those conditions can change to these more dangerous conditions that we have on the list that you can see in front of you. So I just mentioned in the previous slide the way to make a diagnosis of gestational trophoblastic neoplasia. It's about seeing those beta HCG levels that continue to increase after the pregnancy event. So you have had the partial mole, you have had the complete mole, manual vacuum aspiration has been done, but the beta HCG levels continue to go up, or the beta HCG levels are static. So those are the two ways to tell that what you have is gestational trophoblastic neoplasia and not hyaditiform mole. Then sometimes you can detect metastasis on X-ray. Sometimes you can look at histopathology results. Sometimes you just discover it clinically. You are examining a woman who had incomplete abortion 3 weeks ago. They continue to bleed. And then you check the vagina, you see a bluish lesion there, a bluish growth. Usually that means you have a choriocarcinoma there that has spread to the vagina and so on. So that is how we make this diagnosis. Then how do we treat hyaditiform MOS? So meaning, how do we treat partial MOS and complete MOS? So usually we do an MVA. So we do a manual vacuum aspiration. The way we do a manual vacuum aspiration for incomplete abortion, all we need to remember is that these ones bleed a little bit more. So, and therefore we usually do it in theater, because if the bleeding gets worse, then you can easily say, let's do hysterectomy and so on. So we do these conditions in theater. We do manual vacuum aspiration. Some people even curate the uterus just a little bit to help to make sure everything comes out. Then during the evacuation, it's advised that you need to have oxytocin ready, so that when there's excessive bleeding, you can run your oxytocin to contract the uterus. And then you need to have blood available. So we know that when the uterus contracts, some molar tissue can be massaged into the vascular system, and the molar tissue can end up in the lungs, and somebody can have embolism and difficulty breathing. But that's why some people say that don't run oxytocin during evacuation. Just run oxytocin after you have finished the evacuation. Unless there's a lot of bleeding, then you can run oxytocin as you evacuate the uterus. So that's about how we treat the hyaditiform MO. We evacuate the uterus, and then after that we do the follow-up. So how do we follow up patients with complete MOS? So we've already said we evacuate. Then you have to do a serum beta HCG within 48 hours of evacuating. Then you can do beta HCGs every 1 to 2 weeks. So again, like we said, sometimes it's challenging in our setup to do this test, because one test is 200 kwacha. So if you're doing it weekly, patients won't afford. So you can do it even 2 weekly, like that. So until you reach that usual 8 weeks point. So what you want to see is that this beta HCG, as you are doing it, whether you are doing it weekly, whether you are doing it 2 weekly, whether you are doing it monthly, when you reach that critical point, which is the 8 weeks point, you want to see that these beta HCG levels are going down. And going down means that they are going down at least by 10% every time you measure the beta HCG. Like if you do it 3 times in a short time, in a week maybe, you want to see that it's going down by 10% every day, then you see that it's going down. But that opportunity most of us will not have. We will do beta HCGs weekly or 2 weekly if we are lucky, or monthly. So, but the important beta HCG to do is that one after evacuation, because it's your baseline. Then you will check and check and check and see if it's going down at the point you reach the 8 weeks point. If it's going down at the time you reach the 8 weeks point, then you can continue doing that beta HCG every 2 weeks until you have a negative, until the levels become undetectable. When the levels become undetectable, then you need to continue for another 6 weeks, 6 months, I mean, from the point at which they became undetectable. So that is a very important point. So you are doing your beta HCGs, they become negative or they become undetectable. In a case of a complete MO, you need to continue monitoring those beta HCG levels 6 months from the point at which the beta HCGs became undetectable. If by 8 weeks they are already undetectable, that's 2 months, then you need to continue doing your beta HCG for 4 more months, which is now a total of 6 months. So at 8 weeks, your beta HCG is undetectable, then you have to continue for 4 more months to make a total of 6 months of follow-up. So once the follow-up is complete, these patients can be discharged and they can go back to their normal lives. In a situation of a partial MOR, the situation is a bit different. So what happens in a partial MOR is that you just continue doing the beta HCG levels. If you have 2 beta HCGs 1 month apart that are negative, then this patient is cured. Then the follow-up can stop. So that's really the big difference between the two. I hope I haven't confused you, but that's the whole idea. The idea here is that you follow up a complete MOR a bit more than you do a partial MOR. And that is if you are lucky enough to even have histopathology. That's why when you have a molar pregnancy, it's very important to get that tissue because it means something for the patient in terms of follow-up, in terms of how many beta HCG levels you have to do, and so on. And these are expensive tests for most of our patients. So we've already talked about how you evacuate using MVA and how some people curate and so on. Then we come to the management of gestational trophoblastic neoplasia. So this is a patient whose beta HCG levels have not gone down. You've been monitoring that 8 weeks we talked about, and it looks like they're just going up. That patient, you have to make a diagnosis of gestational trophoblastic neoplasia because the beta HCGs have continued to go up even after evacuation. So in that patient, you have to investigate, do your beta HCG levels, again, do your X-ray, do your liver function test, do your renal function test, do a skull X-ray, do a chest X-ray we've already talked about. Sometimes if they present with convulsions, like we said, for these patients, you might need to do a brain CT scan. I've put biopsy there to discourage that, you need to be careful about biopsying molar tissue because they bleed. So you can just end up with somebody who bleeds to death. So if you have somebody who you are suspecting gestational trophoblastic neoplasia and they are not bleeding, just avoid taking a biopsy. The diagnosis has been made by the beta HCG levels that have been going up. And after you make the diagnosis, you do your investigation, you have to do what is called the risk scoring for this patient. So risk scoring, you can look it up. It means that you try to risk this patient. Is this a high risk gestational trophoblastic neoplasia or is it a low risk? So for you to tell if something is high risk is if the score is above 7. If the score is below 7, then that patient is a low risk. So you look at metastasis. Does this patient have a metastasis? And these metastases, how many are they? So you look at the number of metastases, you look at the location of the metastasis, and you look at the site of the metastasis. That is 3 parameters. Then you have to look at the age of the patient. So when you look at the metastasis parameters, you score from 0 to 4. So you score the sites from 0 to 4. You score the number of metastases from 0 to 4. You score the site of metastasis from 0 to 4. Then you look at the age. The patients who are aged above 40 are high risk. The patients below 40 are low risk. You look at beta HCGs. If it's high, very high, 100,000, it's high risk. If it's below, it's low risk. So all these scorings you do. If the time from the time the patient had their pregnancy to the time they present is longer, then these patients will have a higher scoring between 0 and 4. Then if the pregnancy event was like a term pregnancy with a baby, then those patients would be higher risk than patients who have who are demolar and then they end up with gestational trophoblastic neoplasia. So And then if a patient was on chemo before and they've come back, that is also a high risk patient. So you grade all these between 0 and 4. If your number at the end is above 7, then that patient is high risk. If the number is below 7, that is a low risk. Then you also have to stage this cancer now because it's just gestational trophoblastic neoplasia. So it's stage 1 if the cancer is localized to the uterus. It's stage 2 if other genital structures are involved, the ovaries are involved, the vagina is involved. That is stage 2. If it involves the lung, that is staged as 3. If it involves other places, brain, liver, kidney, then that is stage 4. Then what is the treatment? So the way you treat is that you treat according to the risk. So if a patient is graded as low risk, they get methotrexate. That is what those letters stand for over there. So you have EMACO there. E stands for etoposide, M stands for methotrexate, A stands for actinomycin D, C stands for cyclophosphamide, O stands for oncovin or vincristine. So if somebody is high risk, they get all those 5 drugs that I've mentioned. If somebody is low risk, they just get 1 drug, which is methotrexate. And then they get these drugs, usually they get them in 1 week. Then the next week they have a rest. Then they get them in the 3rd week. Then in the 4th week, they have a rest. Then they get them in the 5th week. And in the 6th week, they have a rest. So as they are being treated like this, beta HCGs are being measured now weekly because now we have a big problem here. So we are measuring these beta HCGs weekly as we treat the patients. And we want to see a lowering of the beta HCG. So once the beta HCG has become undetectable, then that's where the treatment ends. So the treatment ends when the beta HCG has become undetectable, but we have to follow up these women for 1 year after the end of the treatment. So once the beta HCG have normalized, we need to follow up these women for a total year after the completion of the treatment. So that is important to remember. Then, so that is the follow-up for somebody with a GTN or gestational trophoblastic neoplasia. Then in the next pregnancy, or let's say during the follow-up, you need to make sure that these women are on contraception, because if they become pregnant during the follow-up, you won't know if the disease has recurred or the beta HCG levels are due to pregnancy. But on top of that, you also need to remember that it doesn't mean that if somebody is discovered with a pregnancy during this period, then they must get a termination of pregnancy. No, but it's something that can be discussed with the woman if she's concerned about the follow-up, and if her risk is very high, it's better that she's not pregnant until the follow-up is completed. Contraception, you can use the combined oral contraceptive pill, but patients can fail to comply. So you can use those injectable ones, Depo-Provera, noethistyrone. Those things are better because compliance is assured. But what you should not use is IUCDs, because in gestational trophoblastic neoplasia, IUCDs can easily perforate the uterus. So we need to avoid IUCDs. So that is about the follow-up of these patients who we've diagnosed with gestational trophoblastic neoplasia. When they become pregnant next time, some people say that after they deliver, maybe you have to examine that placenta and see if there's any risk. But some people say there's no problem with that. They can just deliver and go on with their normal lives if their follow-up has been done properly. Yeah, I think that was the last slide. This was a lengthy presentation and so on, but I can invite people with questions because this topic is a bit technical, but I think it's simple enough for everyone to understand. But I can invite some questions in the next 5 minutes or so, then we can discuss. Hello. Can people hear me, or I've been talking to myself?
We can hear you.
Yes. So I want you to ask. The one who said we can hear you, I want you to ask.
Yeah, good afternoon, Doc.
Yeah, good afternoon. Thank you.
Fine. My question, I missed the explanation on the staging of cancer.
Staging of gestational trophoblastic neoplasia, yes. What did you miss?
Yes, I think I missed the whole column. I was at a place where the network was not so good.
Okay, so there are two things there. There's what is called risk scoring, and there's what is called staging. So the most important thing in the management of gestational trophoblastic disease is not really the stage of the disease, because this condition is very treatable. Over 90% of the patients get cured. So the critical point is the risk scoring. So I'll go back to the staging. So staging, if the cancer is localized to the uterus, then it's called stage 1. If it's affecting other genital structures, your fallopian tubes, your ovaries, it's affecting the vagina, usually it metastasizes to the vagina, that is stage 2. Then if it's affecting the lungs, because the lungs are the easiest place this tumor metastasizes. Like we said, when you're evacuating it, some of those tissues go into the vascular system and they end up in the lungs. So the lungs are the easiest place for this condition to metastasize. Then the fourth, stage 4, is when they're in other places, the brain, the liver, the kidneys. That is stage 4. But what you need to remember is this one, because this one really is an exam question. What are the parameters that are in the risk scoring? I don't think that if we have, like if I have a 7th year, I think I can ask what parameters are high risk for a patient with gestational trophoblastic neoplasia. Or I give you a clinical scenario and I tell you to identify the high risk features in the patient. So presence of metastasis, so that is 1, site of metastasis, number of metastasis, and site, number, and size of metastasis. Then the age of the patient, are they below 40, are they above 40? Then your beta HCG levels, if they are very high, that's a high risk patient. Then how much time has passed? Because you remember that these conditions usually start with a pregnancy event. Sometimes it's a term pregnancy, a baby cries in labor ward, like the latest patient I had. She had a baby, she delivered in our labor ward. I think she delivered by C-section. Then 4 weeks later, I think 6 weeks later, actually, she came and said she was still bleeding after delivery. Then we did beta HCG, it was high. Then we said, maybe your beta HCG from your normal pregnancy hasn't just calmed down. So she came after a month again to do beta HCG. Again, it was high. So gestational trophoblastic neoplasia can come even after an ectopic, even after a normal pregnancy. But commonly, it happens after a partial MO or a complete MO. So we need to say from the event, which could have been a normal pregnancy, an ectopic, a partial mole, or a complete mole, how much time has passed in months. So if a lot of, like if the time has been over a year, that's very high risk. You grade that as 4. You give a score of 4 for that. If somebody comes after a year, after the event, that is graded as 4. Then if you have, what was the pregnancy event? So if you had an actual baby in labor ward and then you end up with GTN, that is a high risk. So you get a 4 for that. Then if you had chemotherapy before, because some patients get a condition like a complete mole, and some people in other countries give prophylactic chemotherapy to people who have a complete mole, because you know there's a 20% chance of it becoming a gestational trophoblastic neoplasia. So some people give some methotrexate prophylactically. So if a patient had received chemotherapy before they come now to the hospital, that is high risk. That is also scored as a 4. So this is the more important thing when you talk about gestational trophoblastic neoplasia. It's the risk scoring. So if the risk scoring is above 7, then you're high risk. Then you get all those 5 drugs that we talked about, the EMACO. If your risk scoring is below 7, then you get just 1 drug, methotrexate. Some places give 2 drugs, actinomycin D and methotrexate, but a lot of research has shown that whether you give 2 drugs, actinomycin D and methotrexate, or methotrexate alone, the response is very similar. So if you have a low risk, a patient who has been graded as low risk, then they get just methotrexate, like we explained. And if you have a high risk, they get those 5 drugs. So that is about the question that has been asked. Is there any other question? Is there any other question? You're free to, yes, ask please.
Yes, I wanted to find out how long is the treatment for if you're giving methotrexate for GTN and the other one, the partial mole.
Yes, so so what we do is that you don't give any methotrexate for partial moles and complete moles. No, don't give, because you know when a patient comes back later, because partial mole and complete mole is not GTN. Those are HYDITIFORM moles. So if you give them methotrexate, when they come back, they'll come back as high risk, and the chemo, they might not be responsive to chemo because you already sensitized them to chemo before. So it means that you've made this patient a very high risk patient if they come back. So don't give chemo for partial moles and complete moles. So that's the, I think that's what we follow in this country. So we don't give methotrexate for partial moles and complete moles. We are only giving those drugs for GTN, and we've said how to make that diagnosis. Then on your next question on how long, we said already that you are giving weekly, then you have a week of rest, then you give another week, then a week of rest, then another week, a week of rest, like that, and you are measuring beta HCG levels. So you don't stop treatment until they are undetectable. That is how you do it. So when they become undetectable, then you have to follow up this patient with beta HCGs again for a year from the point the beta HCGs became undetectable. So if they're undetectable up to the end of the year, then this patient gets discharged and then they can become pregnant. And during the follow-up, they've been on contraception like we've already described, preferably injectables, oral contraceptive pills, but you need to avoid IUCDs because you can perforate the uterus. Yeah. Is there any other concerns, or is the answer clear?
It's clear.
Yeah. Any other concerns?
Yes, Doctor. Good afternoon.
Good afternoon.
Yes, I wanted to find out. I think I missed you when you were trying to explain on the beta HCGs when you are doing the pregnancy test. When it comes out negative, I missed what you explained on that part. I think because of the network issues. It's just a clarification.
Yeah. So you can just Google what the hook effect is, HOOK. So it's called the hook effect. So somehow, because the beta HCG levels are so high, they kind of saturate the test. They get in the way of each other. Kind of the way, let's say you're at a football match. Are you getting me?
Yes, Doctor, I'm getting you.
Yeah, you're at a football match. Yeah, you're at a football match. And then you have a very small door to enter. Then you are trying to fight to enter through that door. You are a million of you. In the end, you end up no one entering, isn't it?
Yes.
Yeah, because you are getting in the way of each other. So that is how the hook effect works. So there's so much beta HCG that the molecules are getting in the way of each other, so much that they can't even attach to the receptors that they've put on the normal pregnancy test. So then you end up with a negative test. And the way to get a positive test is actually to dilute. So you dilute the urine or the blood, whatever you are using, or the serum, you dilute it, and then you get a positive test. So that's the explanation.
Okay, thank you so much, Doctor.
Yeah, does that make any sense?
Yes, it does. I was trying to wonder how best you do the diagnosis. In this case, when you do I think the common ones that we have at the moment are these, the urine sticks, the pregnancy tests, these strips that we have. Now, when maybe when you try to do the quantitative one, maybe in this case could be more helpful in this case. So I was just trying to wonder. Yes.
Yeah. So when you do a quantitative one, it will detect. We had a patient, I think it's 3 months ago. So the pregnancy test was negative. Then I said, no, when I saw the patient, I was asked to see the patient. I saw that this patient looks like a GTN because she had a mass on the cervix and people are trying to get a biopsy for cervical cancer. Then I said, no, this doesn't look like cervical cancer. This looks like molar tissue. But when they did a grav index, they said it was negative. Then I said, let's repeat. I see for myself what the grav index result will be. So when we did a test and looked again, there was a very faint line. You had to look very closely for you to see that it was actually positive. And then we said, let's do a serum beta HCG, a quantitative one. And it was really high, above 100,000. So that's how that this hook effect is not a rumor. It happens in practice, that you can have a negative pregnancy test when actually the beta HCG levels are quite high. Yeah. Is there any other question?
Yes, so in terms of diluting, what do you use to dilute the urine? You use the normal saline, you use water for injection, or what else?
Yeah, you can just use normal saline. I think you waste a lot of water for injection, but you need to measure how much you are diluting it. So your urine, if you have 1 ml, you put another 1 ml and see if it becomes positive. Then you continue putting the same volume, like they say titers. So you keep on diluting and keep track how much you are diluting for it to be positive. Because you can estimate the quantity of beta HCG by the amount of times you diluted. Because you know the very sensitive beta HCG urine tests, they become positive when the beta HCG is about 25, mil international units, or about some of them even at 5 mil international units, the very sensitive one. So you can have an idea how high it is by the number of dilutions that you did. So just keep track of the number of dilutions that you are doing. Yeah.
Thank you, Doctor.
Okay. Is there any concern? Or we can say we are done.
Good afternoon, Doctor.
Good afternoon.
I just wanted to ask, like, this woman who has GTN,
Yeah.
or molar pregnancy, then put on family planning. Like, how much period should this woman be given in order to conceive again? When can she conceive? Like the advice, after how many years or after how many months?
Yeah. So if you are following, it depends on what she had. Did she have GTN? Did she have a partial mole? And did she have a complete mole? So that's what it depends on. So if she had a partial mole, which is the mildest form of gestational trophoblastic disease, you do your beta HCGs. If two of them are non-detectable 1 month apart, then that patient is cured. They can go on and become pregnant. Then you have your complete mole. Your complete mole, the minimum follow-up time is 6 months from the day of evacuation. But if the patient, the beta HCG levels haven't gone back to undetectable for a long time, then you need to follow them up for 6 months from the point the beta HCGs become undetectable. So if it's undetectable at that point for a partial mole, that patient can just go on and become pregnant. So from the point you stop the follow-up, you need to add 6 months. Then that patient can go on to become pregnant. I think I've mixed up a little bit there. So you have a complete mole, you follow up, then the beta HCGs become negative. You have to follow up for 6 months from the point they become negative. If they're still negative, then that patient is cured. They can go on and become pregnant. Then you have the last case, the most severe case, which is a gestational trophoblastic neoplasia. For these patients, you need to treat them. You finish treatment. Then from the point there you have finished treatment, you need to follow them up for a whole year after that. Then after 1 year of follow-up, from the point they finished treatment, then that patient can become pregnant. So really that's the summary of it.
Okay, thank you.
Yeah, maybe I can also add that there's a role for hysterectomy in these patients with gestational trophoblastic neoplasia. So if you have a patient with tumor that is localized to the uterus, they are high parity, hysterectomy helps. You can actually cure them by doing a hysterectomy. I think that has to be added there. So there's a role for hysterectomy in the treatment of gestational trophoblastic neoplasia. Yeah, it's interesting that